Welcome to Let's Talk, a place for straight talk on hard topics with smart people. And I'm pleased to be here today live from the SNMMI meeting in Toronto with Dr. Rich Wall. So thanks for joining us, Rich.
My pleasure.
So Rich, you, I think, were the first, researcher and physician to develop a radiotherapeutic that had dosimetry on label with the Bexar work, right? Way back at, I don't know how long ago, a long time ago.
Well, it was, let's see if I got it right. 2002, 2002, I think
We'll
was
call that a couple
Zeppelin, and
decades.
2003 was
Yeah,
Bexar.
we'll give that 20 years. Yeah, I mean, so you're not new to thinking about these things. And it's quite interesting to me that even 20 years ago, you felt this dosimetry mattered
Well, it was, let's put it this way, it was far longer. The first patient-specific dosimetric study that we published with radioimmunotherapy was in 1992 with an anti-CD37 antibody, MB1 in lymphoma. So remember, the FDA approval only occurred, which was in 2003. That was after all these studies have been done. So this has been over 3 decades.
So, but what's different now? Because today, people have an idea for a new drug. They take it to the FDA, and dosimetry is required in phase 1. Then mostly, if successful, they move on to phase 2 and phase 3, and then there's no dosimetry in those phases. You carried it all the way through to label, to the end. Was there anything different about that situation?
Oh, there were several things different. I mean, so when we developed radioimmunotherapy of lymphoma, and basically that was the first radioimmunotherapy ever FDA approved. And the Bexar did have dosimetry built into the label. I mean, there were like at least three reasons we did that. One, the CD20 antigen target is on normal B cells and it's on the normal spleen, so it's not tumor specific. So we had to figure out how to deal with that, and that was giving unlabeled antibody first, and which would block a lot of the sites, and then give the labeled antibody. But despite that, there was patient-to-patient variability. So you got an antibody that cross-reacts with normal tissue. So we expected and observed substantial patient-to-patient variability, which was up to 5 or 6-fold. So with that variability, if we had developed it in the standard way without dosimetry, we would have systematically underdosed.
Yeah.
Probably 70% of our patients have a safe dose,
Right.
because patient-to-patient variability was high. Second thing was the mouse, and it was an antibody that was made in a mouse originally. So we could only give one dose. We thought we could only give one therapeutic dose. So we couldn't give okay, here's a dose, and then 2 months later, here's a dose, and then 2 months later, here's a dose.
Right.
We wanted to give, one shot. The beauty of it is there's a single therapeutic dose. We were eventually able to repeat it in patients who had no human anti-mouse antibody, but we wanted to get this one dose in and get in as much as we could safely.
Yeah.
So our dose escalations were all based on patient-specific dosimetry using an imaging study.
So were you targeting an absorbed dose to the tumor?
The absorbed dose was to normal tissue.
Yeah.
So
Okay.
we did
It was
a dose
normal tissue.
escalation based on normal tissue absorbed dose, and with both the MB1 and the anti-CD20, which became Bexar. So patient-specific absorbed dose from a dosimetric dose that was part of the regimen, and then that was used to plan the therapy dose, which was patient-specific. And then the third thing was, antibodies are very specific, but they have problems. And a lot of the progress in radiopharmaceutical therapy lately has been with radioactive peptides. So some of these radiopeptides go to the tumor better than did the antibody. So I think the therapeutic window we had available with these sort of first-generation agents was tighter. So we really had to get it exactly right to hit the sweet spot to make it effective. And it was incredibly effective.
Right.
So those were at least 3 reasons we went for that. But with the radiopeptides, let's just talk about PSMA targeting. Those are given, right now, they're being given in 4 to 6, and say 6 injections, and the patients are sort of followed every 6 weeks to 8 weeks and retreated. The tumor to background ratios are higher, so there is efficacy and probably a little better safety profile than requiring dosimetry for every patient. So they had enough safety they could get it approved. But I would point out that the improvements in outcome, though real, have been something like 4 to 5 months. So my concern and sort of assertion is we probably could do much better than that 4 to 5, 6 months if we adjusted better for the individual patient. I think we're kind of underdosing in general with the
Yeah.
prostate
And do
therapy.
you think by spreading a treatment over 9 months, we're giving those tumors time to morph and, change their response to the same drugs, and
Yeah,
that there's a
I
risk?
personally think that the way we're dosing right now is uh, we're giving a lot of our administered activity after the tumors have responded.
Yeah. Right.
Dr. Hoffman, who I hate to paraphrase him, maybe you should ask him, but he gave a talk at the SNMMI meeting we're talking in Toronto about how giving these doses, when the patient responds well, giving additional doses when they've already responded really well may not be necessary. That de-intensification and then maybe treating later is more rational. And I think we're probably going to move to a higher administered dose at the start. It may be a patient-specific dose, and hopefully with this sort of improved dosimetry and dosing, we'll be able to have a completely different paradigm on how we give this and have the patients live longer. As we do better, then this issue of, can I give more doses? Am I going to hit critical organs? Of course, we don't actually know how critical the renal dose is. We don't want to give too much, but renal toxicity can be late. But knowing these kind of numbers will really help us inform these dosimetric numbers. I think will help inform these decisions.
One last question on the Bexar experience, because you're, one of the few people who've been developed a drug and have, seen it play out, long term in the clinics and how it was applied. Do you think that the effectiveness of that therapy would have been different without the dosimetry on label for those patients? And said differently, do you think including the dosimetry limited access as well, though, that complicated it on the clinic side and maybe fewer people received the therapy?
Yeah. Okay. So do I think dosimetry was important? Yes. That's why we built it in. Do I think it was better with dosimetry? Yes. Do I think that when we got a 96% response rate in untreated patients with a 76% complete response rate, where the responses lasted 6 years and we got patients out 20 years from a single dose given over an 8 to 14 days, I think the dosimetry made that possible. But this is always a question: is perfect the enemy of the good? Would it have been an effective therapy if it didn't have dosimetry and we just gave a millicurie per meter squared dose or something? It probably would have worked. It probably would not have worked as well. And I mean, if you having to do dosimetry on everybody 30 years ago, 25 years ago, when it wasn't standard, was a burden, and I think it was a barrier to uptake. I mean, one of the challenges then was there weren't necessarily fee codes that were used that people knew how to use for dosimetry, and it was all new. There were a lot of obstacles. So yes, it would have probably been used more widely if dosimetry wasn't there, but it might not have been if the efficacy wasn't there, because the reason it was viewed as perhaps one of the most effective and well-tolerated drugs was because it was effective and well-tolerated with dosimetry. So it's a hard guess.
I mean, I'm not an expert on this drug, my sense is, wasn't one of its biggest challenges that it was an inpatient procedure? I mean, that's probably...
Oh, no. Well, I mean, it wasn't an inpatient.
Oh, it wasn't? Oh,
well,
I thought it was.
Let's put it this way. It was originally, but we were able to get the laws changed in virtually every state to allow it as an outpatient, because we could measure the radioactive exposure from the patients, and it was all below the 5 MR expected dose to the public. So it could all be done as an outpatient at the doses we were giving. I would just point out that we also did a dosimetric study with Zeppelin. We published it a couple of years ago. I think you're familiar with it. It was in cancers, but there, using indium and organ dosimetry, we were able to take the injected dose up to over 5 times the FDA-approved label dose with an 85% response rate. It was a substantial response rate. So the fact that we could safely give that dose much higher, now this was in the setting of stem cell transplant, means that dosimetry can let us push doses higher. And generally with radiation, more dose is associated with more anti-tumor effect.
Applying that to the modern drugs, some of the studies I've seen, I saw a medical oncologist give a really nice talk, and he got up there and said, okay, I've got a late-stage prostate cancer patient. Here's my 5 options. It was like 3 chemos, 1 immunotherapy, and PSMA. And he said, here's the data I have on the 2-year outcomes, of each of these drugs. And it was exactly the same. I forget that 4.0, 4.0, 4.0. And then I was so disappointed to see, well, there's our theranostic performing well, but not better than these other methods. Obviously, that's based on the current on-label procedures, one size fits all, no patient-specific personalization. How important do we need to find a way through this challenge of personalized dosing might be too strong a phrase, but a way to have, managed care protocols that factor in the unique pharmacokinetics of the patient. If we can do that, is that important to the success of this field?
Oh, I think it is. And but just remember, our goal is to do something bad to the cancer, but not something bad to the patient. So if you have 4 to 5 month prolongation of survival with a therapy, they're not all equivalent. I mean, cost is an issue, patient inconvenience is an issue, and side effects are an issue. So in the in the session I attended today, it was pointed out that radiopharmaceutical therapy of prostate cancer actually is better tolerated than hormonal. So, and we know it's better tolerated than chemotherapy. So side effects are an issue as well. So yes, you'd like longer survival, and I think that will be achievable with dosimetry. I think we probably need to make these post-treatment specs routine. One time point better than none. Several time points probably better than one. You have to balance, what's perfect and good have to be balanced. But I think we need those data, and I think we're then going to have to increasingly personalize, like dosimetry is part of that, our therapies. So, if you've got the PSA down to almost unmeasurable and the patient has no lesions left, you might stop.
Great having you here.
Really a pleasure to meet you.
Yeah.
I've heard a lot about you.
Oh, yeah. Thanks for joining me and Dr. Wall today. Let's talk again soon, Rich.
Yeah, maybe in a couple of years.